allow me to introduce myself briefly. My day-to-day job, I'm the Senior Program Officer in the Quality Assurance Unit, and I'm based in the regional headquarters of the University of the West Indies. It's my pleasure to be here with you this evening, and I'm walking in the footsteps of my friend and colleague, Mrs. June Weekly Holness, who was actually the moderator of last month's session. Of course, we all know, and that's why you're here, that this evening's teleconference will focus on breast cancer. And we have for you tonight a lineup of highly qualified persons who will help us to explore epidemiological issues of incidence, mortality, and preventative strategies. We're going to take a specific look at one group, the younger women, who we find these days have been diagnosed with metastatic breast cancer. So we have to ask what's going on with this particular demographic. Now, you're also aware too that the care and treatment of cancer can be rather expensive. And so how can you afford it if it happened that you fall victim to cancer? So this evening, we're going to be exploring critical illness insurance and how to make it affordable for the ordinary person. We have three very, very special guests with us this evening as well. Three breast cancer survivors who will be sharing with us their stories. Among these, we have one guest who is going to give the lie to any belief that you and I might have that breast cancer only affects women. So at the end of our time together this evening, I know we will all have become that much more knowledgeable about breast cancer and how it is that we can help to prevent it from happening in our lives, or if not possible to prevent it, but function in ways that can ameliorate the effects on our lives. So once again, I welcome you and I thank you for joining us today. To begin, I'd like to invite Ms. Dorothy Satchwell, and Dorothy is the founder and chair of the MistyBlue Cancer Care Foundation and herself a cancer survivor. Dorothy is going to give us some opening remarks. Dorothy, over to you.
Thank you, Dr. Perkins. Ladies and gentlemen, good evening, and thank you very much for joining us. As Dr. Perkins said, this is our third telecast in this series of cancer teleconference that we have been having since August. This month we'll be looking at breast cancer, and as you know, that's something I'm very passionate about because that's the cancer that I was diagnosed with. And it is also that cancer that I believe a lot of persons are drawn to because of the nurturing aspect for women, because there's this misconception that it's only women who have it. And this even will be able to address those myths, and then we'll be able to have a better understanding of who is at risk and all of that. Let me give you a slight rundown quickly of MistyBlue Cancer Care Foundation. It's a cancer support education group that operates out of the parish of Westmoreland. We have been in operation for the last since 2015, and what we do, we have diagnostic health fairs and educational health fairs where we try to bring some amount of awareness to the people of Westmoreland and its environs as to some of the things that they need to look at to understand about themselves in having some amount of awareness about cancer. And because of COVID, we have not been able to operate in our normal way since March. So we thought of having these teleconferences where we can keep you up to date in terms of what is happening, because now with COVID in the forefront every day, we tend to forget that there is cancer. For the year 2018, we lost 1,200 persons to cancer in the parish of Westmoreland. And as you know, to date, even though the 100+ persons who have died from COVID is significant, we realize that cancer is a far bigger problem than COVID today. So we can't afford to forget that it is relevant and it is very much in our faces. So thank you very much, ladies and gentlemen. Thank you to our presenters. Thank you to our hosts. And I hope that this evening we will again have a fantastic and educational evening. Back to you, Dr. Perkins, and thank you very much.
Thank you very much, Ms. Satchwell. And that was a great way to welcome us as we continue with this evening's program. Just to say to our audience, remember, we're happy to take questions and comments. So make sure to write your questions and comments on the relevant platform, and we'll take those when we get to question and answer closer to the end of our time together. Now we're going to move into our first presentation, and that will be done for us by Dr. Mong Ong, and he's no stranger to these teleconferences. The last one I joined in, Dr. Ong gave a fantastic epidemiological presentation, and I can assure you that this evening he will do just as well. Now, he's going to do two related presentations for us. First, he's going to break down for us the data on the incidence and mortality of breast cancer in Westmoreland, and he will look at between 2004 and 2018. And once he's completed that particular presentation, he's going to look a little bit more closely at the epidemiology of breast cancer and talk us through the preventative strategies. Now, by way of quick introduction, Dr. Ong is the medical epidemiologist and head of epidemiology and research unit of the Western Regional Health Authority right there in Montego Bay. He teaches epidemiology at a couple of our local universities, and he's also a visiting professor at the University of Alabama at Birmingham in the USA. Among Dr. Ong's research interests, you can find surveillance of both communicable and non-communicable diseases. So clearly, he's very well placed to present and interpret data and interrogate epidemiological matters. And he will speak to us for 30 minutes. Dr. Ong, thank you so much, and over to you.
Thank you so much, Madam Chair, Dr. Perkins. Thank you so much for the lovely introduction. Can you all hear me well? Very good. Okay. So I would like to start by saying that thank you so much for the Misty Cancer Care Foundation for giving me this opportunity. I am honored to be a part of this series of presentation, a series of this teleconference. And I would like to thank particularly to Foundation President for giving me this opportunity. Let me share my screen. Did you say 30 minutes? I thought I was given only 10 minutes. So I was trying to consolidate my presentation, but I'm glad to hear that you give me the 30 minutes.
We'll give you as much time as you need, and up to 30 minutes, but if you go shorter, just more time for question and answer.
Very good. All right, thank you so much. So I'm going to do the presentation on breast cancers, but I just want to emphasize the fact that breast cancer not only affect female population, it is also affect male population. So keep that in mind. This is the outline of basically my two presentations. I'm going to start by saying some numbers, epidemiology of breast cancer, some of the descriptive epidemiology, and some of the risk factors. And most importantly, I'm going to highlight some of the evidence locally. You know, we tend to look at international and others, but we are now going to be looking at some local evidence as it relates to breast cancers. And now I'm also going to be saying something about the what Ministry of Health and Wellness is doing, on local Ministry of Health is doing in terms of prevention and treatment of breast cancer. And I'm going to be end with the summary of the presentation. Just to refresh our memory, what is cancer? Cancer, also known as malignancy and also known as neoplasm. It is a large group of diseases that can start in almost any organ or tissue of the body when abnormal cells grow uncontrollably, go beyond their usual boundaries to invade adjoining parts of the body and or spread to other organs. There are a little over 200 different types of cancer that can occur in our body. So basically in the past, you know, we know that cancer is the disease of age. So when you are getting older, if it is unfortunate, you're going to end up with one of those diseases, such as cancers. And with that concept, when we looked at the total population structure of Jamaica, when you look at the bottom of the slides, you can see there's a 50 years projection of the population pyramid in Jamaica. When you look at on your left, 1970, you can see the nicely shaped pyramid there, and most persons are in younger age group. When you hit to 2020, we are right here at now, and 2020, we have started to see the younger generations are getting less and less, and persons with age and persons who have previously may have died or might have died from the infectious diseases and so on, and even non-chronic communicable disease such as hypertension, diabetes, based on the technology advance and also the availability of the medications and medicine, pharmaceutical drugs, as well as the technology of diagnosing those diseases. persons with the diseases or chronic non-communicable diseases, and such as hypertension and diabetes, they are living longer. So we are starting to see persons are going up, the upper part of the pyramid is starting to get shaped. And when you touch 2050, it is anticipated that we are going to see that type of pyramid, meaning we are seeing less persons in younger population and older persons in younger population. So we have to align, we as in health service providers have to align ourselves. How are we going to be dealing with those population, larger population? It is going to be becoming living longer, and with some of them are going to be living with disease and such as cancer. How are we going to deal with it? And on top of it, there's another contributing factor is that our fertility rate in Jamaica from 1950 to 2020 are steadily declining. That's one of the contributing factors due to the fact that we are not seeing less younger generation in our population. That's one of the contributing. In 2018, Globacon they published a paper, Global Cancer Statistics from 185 countries of 36 cancers from 185 countries. And in that published paper, for female population, breast cancer is the most diagnosed cancer and leading cause of deaths among female population. Now, in daily life, when you assess the person's or individual, how well he or she is doing by way of looking at how well he lives or she lives in his or her life, and how well educated he or she is, and also how much he earned. Similarly, when we look at the country, we are looking at the population of the country, how long they are living in terms of lifespan, and how high their education status are, and also how much they are earning as a gross national income, GNI. So that's where we have introduced the Human Development Index, HDI. So when you are scoring a country, if you see a country with higher score, meaning the persons are living longer, well educated, and they are earning more money. So that is going to be a reflection of how well as a country is doing. So let's look at that GNI and how impact that GNI on cancer status. And when you look at this is the top 5 leading causes of death in global community. And when you look at it, for those with higher GNI, the second leading cause of death are malignant, neoplasm. So when you look at the low HDI countries, cancer is not necessarily the second leading cause of death. It goes all the way down, but second leading cause of death is the infectious diseases. In this regards, due to the fact that some countries are still struggling with communicable diseases. And when we look at, let's look at where Jamaica is. Jamaica is classified as high HDI, and based on that classification, we also know that in Jamaica, cancer is the second leading cause of death in our population. In terms of cancer burden, now coming back from the global picture to the Caribbean, when you look at the Caribbean, also in statistics from 2018, and female population, breast is the most diagnosed cancer and leading cause of death among cancers, followed by colorectal cancer, lung cancer, cervical cancer, and uterine cancer. Now, coming to the country, Jamaica, a similar pattern is going to be seen here. And 2018, breast cancer is being the leading cause of cancer among female population, followed by the similar pattern one you saw in the Caribbean. WHO also published the paper, and this paper also shows similar pattern here when you compare in the female population breast and cervical cancer. Incidence is much higher in breast cancer among female population, and mortality also is higher compared to cervical cancer. Now, looking further detail as to the countries rank of Jamaica in terms of cancer in non-Latin Caribbean countries, we look at 14 non-Latin Caribbean countries, and Jamaica ranked 5th in breast cancer incidence and ranked 7th in breast cancer mortality among 14 countries. Now, published papers in Jamaica, this is 45-year cancer trends, and huge published papers published in the local and international journals. And 1958, and they have found that breast and invasive cervical cancer is the leading cancer mortality sites in females. 1988 to 1992, similar trend, and the adult cancer of the body of the uterus is the third leading cause of breast cancer sites. And 1993 to 1997, as similarly, breast featured first leading cause of cancer sites. And 1998 to 2002, also again, breast cancer is the leading cause of cancer among the remaining cancers in female population. In Jamaica statistics, annual number of deaths, cancer mortality trend, when you look at it, the total population, total line is on the top and female line is at the bottom. And you can see from 2006 to 2017, we are seeing the more number of deaths reported due to cancers. For mortality rate for cancer, that's all cancers. And you can see also similar trend. We are seeing the upward trend of cancer mortality rate in Jamaica. Now, when we look at the female population, first leading cause of deaths among female population is cardiovascular disease, and followed by all cancers. So cancer is what you saw previous slides, second leading cause of deaths among population, and also applied to the female population. Now, looking at the local data, which is a little bit outdated, but is still relevant to these days. And when we look at from 1998 to 2002, female population, we have 27.1% of all cancers seen in Cornwall Regional Hospital due to breast cancer. And 2003 to 2007, jumped from 27.1 in 1998 to 35.8%. So we are seeing more cases of breast cancers in the health facilities as well. For Western region, which has 4 parishes, St. James, Trelawney, Westmoreland, and Hanover, when we look at the female population again, Western Regional Health Authority from 2008 to 2011, top 5 cancers, breast cancer is at the top. Now, persons who end up with the breast cancers are ended up in the cancer care center in Cornwall Regional Hospitals, either by radiotherapy or either by chemotherapy. So 2 modalities that they are doing, or 3, surgery as well. When you look at from the data from 2014 to 2018, number of cases has increased drastically. That is being seen as an oncology department. So by now, you realize that breast cancer, both incidence and mortality are increasing in Jamaica, and that is also in line with what we are seeing globally. Now, when we look at our Westmoreland data, we don't have a detailed data on Westmoreland, and again, I would like to emphasize the fact that Westmoreland also follows the global trend as well as the national trend. Westmoreland, the parish, who are not from Westmoreland, who are not familiar with the West Parish of the Westmoreland, is located in the western of the island with a total population of 145,000, a little over 145,000. And they have a place called Negril, well known internationally for tourist attraction. And most of the Westmorelands work there. And we have population, younger population work in the tourism industry. And also, Westmoreland has a farming community, especially in the eastern part of the parish. As you can see from the previous slides, the population in Westmoreland is also increasing over time. And like I said, the population increased, and we are seeing our population is aging, and we are seeing more persons over 50 and over living in Westmoreland parish. When it comes to male to female ratio, there's not much difference there, 1:1. And just to mention that in terms of public health services, health services provision in Westmoreland, we have our primary care, secondary care, primary care being the health departments, health centers. Those are strategically located throughout the parish, and by way of providing health services through type 1, type 2, type 3, type 4, and type 5. We don't have type 5 in Westmoreland. We have up to type 4. And we also have satellite health centers where, you know, the population, the persons, well, the distance area where we cannot reach to the proper health infrastructure. We have satellite health centers which also provide the health services to the population there. We have in secondary care hospitals, we have type B hospitals and 200 beds there, and provide 4 disciplines: emergency services, internal medicine services, surgery, obstetric and gynecology services, and pediatric services as well. And in addition to the government health facilities, we have 1 private hospitals, a well-known private hospital, Royal Medical Center, also provides services including breast cancer screening. And in the public sector side as well, we have many private doctors who are also providing services, including cancer screening. Now, when you recall HDI, Human Development Index, compared to the rest of the parishes, Westmoreland has relatively low HDI, and not only Westmoreland, most parishes in the West has relatively low HDI compared to the remaining parishes. I'm not sure why, but that is what the data is showing. And when we look at the trend in breast cancer trend in Westmoreland, this is for both male and female, top 5 cancer deaths in Westmoreland. This is the data extracted from the registered RGD, Registrar General Department. And for male is prostate cancer, as you can see, in the highest there. And as the year goes by, you're seeing more cases are being detected and the persons are dying from it. For breast cancer under this arrow, and you can see the trend. It's not particular trend that we are seeing, but we are seems as if the number of deaths due to breast cancer are also increasing. For female population in particular in Westmoreland, the cancer deaths contributes 19% of all total deaths among female population, and Westmoreland is also featured there compared to the remaining parishes. And this is not the rate, this is just a number. So, you know, lower numbers doesn't mean that we are seeing less, incident is less in that particular parish. Based on the population that we have in the particular parish, we just use the absolute number to plot graph here. So Westmoreland, in Westmoreland again, breast is the leading cause of deaths among the remaining cancers in female population. And the trend, look at the remaining parishes. Similarly, you can see the breast cancer is being the leading cause of deaths among female population, and 19% of all deaths in female population. So look at the trend of the breast cancer in Westmoreland. We don't see a particular trend. Seems as if at some point it's peaked, and we still see 2010, we have seen the highest number of cases, excuse me, persons dying from breast cancer, and it's come down significantly and going up. But it is also safe to summarize that we are seeing persons who are dying from breast cancer is increasing in Westmoreland. So in summary, Jamaica, classified as high HDI, cancer is the second leading cause of death among in the population, and breast is identified as a leading cause of cancer death among female population. Westmoreland is relatively low HDI compared to the remaining, but for the breast cancer, it is not the highest in the country in terms of cancer deaths. 23% of the deaths among men and 90% of the deaths among female due to cancers. And for female population, top 5 cancers and breast is the leading cause of cancer. There is no specific trend is observed at this point in time, but seems as if we are seeing increased number of persons, female populations are dying from breast cancer. And with that, I'm going to close this session. Thank you so much for listening, and I'm going to pause. I'm not sure if I should take the question now or move to the next presentation. Over.
Dr. Ong, you can move on to the next presentation. and we'll take all the questions and comments at the appropriate time at the end. So we'll just remind our audience that you can send your questions by the platform that you're using. And for those of you who are with us on Zoom, once we come to question and answer, we'll take account of you when you put your hand up. So Dr. Over to you again.
Thank you. I hope I'm not. Okay, can you hear me?
Yes, we can. Please go ahead.
Okay. All right, so now you have heard the numbers and you have seen the numbers. Now we're going to look at epidemiology of breast cancer and what are the preventative strategies that we applied in this particular area of the country. In medicine, everything we do is based on evidence. So what we call evidence-based, and they are being tested and they are being tried and based on the outcome and used as evidence, and we put our intervention, not only for breast cancer, any type of diseases that when we treat in our field of medicine, we use evidence. What are the evidence that we have for breast cancer? They are based on the tested and tried. We know that there are 5 modifiable risk factors that cause the cancers in the population, not only in Jamaica, but also globally. And those are obesity, physical activity, dietary practices, tobacco use, and harmful use of alcohol. Those conditions are put person at the higher risk of getting cancers. And Jamaican perspective, when we look at it, we have all these risk factors. But again, these factors can be modified in terms of preventative measure. So if you are not obese, you are less likely to develop cancer, for instance. So in Jamaica perspective, what we have local evidence is that we have Jamaican Health and Lifestyle Survey, in short, JHLS III, that was done in 2017 and 2016 and 2017. And the key findings that I'm going to be presenting. So 1 in 2 Jamaicans were classified as overweight. So we are actually at risk of getting cancers. 82% of Jamaicans are engaged in low physical activity. Now that we are asked to stay home, and I think that is going to be increasing, stay home, sleeping, or watching TV, or going to Zoom and all of that. I mean, that's not going to be good in terms of lifestyle, healthy lifestyle. However, before COVID, we have 82% of Jamaicans who are engaged in low physical activity. In terms of dietary practices, we love to eat sugar, and that's going to be, we're going to be ended up having diabetes and after the hypertension. And that's also, diabetes is also one of the risk factors of developing cancer. 1 in every 10 consume excess salt or sodium by adding salt at the table of frequent consumption of salty sauces. So salt consumption may lead to the hypertension and other conditions, and that's going to put us in the higher risk of getting cancers. In terms of tobacco use, the same study found that 41% of the 15 years and older use alcohol, and 15% of 50 year and older also use tobacco product, that's a current, and 17% of the Jamaicans use marijuana. But I'm not sure about the data, but 70% of Jamaicans use marijuana. So those are also put us in the risk factors for developing cancer. So general sense, those 5 factors are modifiable risk factors that cause cancer. What about breast cancer? We have what we call modifiable, non-modifiable risk factors. So there's nothing you can do about these risk factors that we are born with it, such as age. Incidence of the breast cancer increases with age, but we are going to be hearing from the expert that younger generations are also developing cancer. So that's the outlier of the norm. But in general sense, incidence of the breast cancer increases with age. It is uncommon before the age of 25, increases to the time of the menopause and then slows down. And again, I said that at the beginning of the presentation, breast cancer affects male and female population. Another non-modifiable risk factor is family history. Approximately 10% of the breast cancer is due to inherited genetic predisposition. a woman whose mother or sister or first relative has a breast cancer is at higher risk, relative risk, 2 to 3 times higher relative risk compared to the other women. And we also link genetic factor to the breast cancer, particularly breast cancer gene 1 and 2. And those are the non-modifiable risk factors for breast cancer. In addition, early age of menarche and late age of menopause is also one of the risk factors for sexual and reproductive health factors that put us in the higher risk of getting breast cancer. I mentioned about overweight, physical activity, tobacco use, alcohol consumption, and also oral contraceptives and hormone drug use. Hormone replacement therapy increase the risk of breast cancer development. For HIV and AIDS, and we also know that that may have increased risk of developing cervical cancer. And for the breast cancer, it may be some connection there. For breastfeeding is one of the good news, the protective effect that we can get from the breastfeeding. So if you breastfeed your child, you may have a protective effect of developing breast cancer in the future. And I spoke about age already increases with the increasing age. So narrowing down to Westmoreland, what you can see over there is an increased consumption of the alcohol may be linked to the development of the breast cancer and obesity as well. When you look at the female population, a male population is in the in the country, I would say in the island, is a second, Westmoreland man ranked second in terms of obesity. We have obese men walking around in Westmoreland. For female population, it's not that bad. 1, 2, 3, 4, 5, 6, 7 in the 14 parishes, 14 parishes. Again, drug use and alcohol use are linked to the development of breast cancers. And when we look at the prevalence of drug abuse in Westmoreland, 34% have ever used cigarette. And alarming is that 37% have ever used of ganja, versus 16% current use. More importantly, 91% have ever used alcohol. 91%, that's almost everyone have ever used at some point in their life alcohol. And alcohol is the most abused drugs in Westmoreland, is being identified by the rapid assessment survey done by National Council for Drug Abuse. 76% consume alcohol to feel good and relax. We are trying to understand these factors because that's where you're going to do the preventative measure. Now we have looked at the risk factors. Now we're going to look at, based on the risk factors and based on the knowledge that they may have, how do the population behave? So the same study that we have looked at, and what we found is, self-breast examination is one of the cheapest methods in terms of screening of the breast cancer. And we teach them we teach the population from time to time. As you can see, there are posters everywhere, all of these things. But previously, we have seen the low coverage of self-breast examination in the population. But in 2016, 2017, we have seen 55% overall. So 5 out of 10 women are doing the self-breast examination, which is good, but we need to see more doing that. And in terms of mammogram, which are one of the modalities that you detect the breast cancer, only 6% women between 40 to 64 years, these are high risk groups. Only 6% in 2016 and 2017 did the mammogram, which is alarming as well. One of the findings that we also found in the West is that how can we impact our health education on the population? Sometimes you try to talk health education and promotion talks and not necessarily translates our talk to the population. So after you talk, and person may be listening to you, but may not necessarily grasp as to what you are talking about. So we try to test by way of showing, we do the intervention study where we started by asking and administering a questionnaire to the persons. And after we administer the questionnaire, we show the health education messages using the PowerPoint presentation. After that, we ask them to re-answer the same questions from the questionnaire. And we started to see people picked up, in terms of knowledge. Meaning if 5% are clearly identified the risk factors, after the presentation, about 50% are identifying the risk factors correctly. So in other words, most in this population instances in our setting, this graphical presentation is very important. Just not talking. By way of talking, person may not necessarily understand what you're talking about. So what we did was after that study, and we followed them up about 6 months and 12 months, and to see how many of them are actually following our instruction. And we see, we followed 30 women, and 22% were screened for breast cancer, and 140% had not been screened, even though 22% is still low, but compared to the previous findings, we have seen increase in terms of picking up. So that sort of intervention is needed in terms of using the graphical presentation, and so the persons pick up and get the knowledge as to what are the risk factors and how do they behave when they know the risk factor for the breast cancers. And also another finding, another study that we have found, fear was found to be the deterrent to participation in the mammographic screening. And it was not, however, the most significant deterrent. So this is also not that significant, but we need to be mindful about when persons are coming for or if you're advising persons to get mammogram, you try to make sure that you encourage the ladies to make sure that, this is not the procedure that's going to be hurting you so much. It's going to have some, but it's not going to have some, motivating the woman to go on and do the mammogram. So this is for the healthcare providers to take knowledge or to take notes from that study. And also interesting to note that studies done in university hospitals and radiology was in the Western Jamaica, trying to see persons who are coming for the mammogram. How did they end up in that facilities for doing mammogram? And 329 in university hospital of the West Indies, the majority of persons are self-referred, meaning they just, go there and do it based on the knowledge that they may have, assuming that, and they just did it. So 73% the majority. And when you compare that to the radiology was in the Western Jamaica, self-referral is only 14% compared to 73% in town, university hospitals. But most persons are coming from their primary care. So this is also a very important note for the service provider. You are the one who is going to be motivating these persons to act on what they know. So please motivate them to go on to do the breast mammogram and other tests so that they can be detected, the cancer can be detected and managed early. And what are we seeing in our setting, which is our health facilities? And what we found in the patients who are coming to us with breast cancers, some of the factors that we have extracted from them, and I listed right here. Ignorance, they're coming too late because they have ignorance. I know it's not going to be happening to me, so they don't necessarily go on for screening. Fear is another factor. Everybody's fear of being diagnosed with COVID-19. Everybody's fear of being diagnosed with diabetes mellitus, hypertension. Nobody wanted to be sick, and nobody wanted to be labeled a sick person. So that fear factor is also a big influence there. And in addition, influence of the family and friends who advise against medical treatment. This is worrisome. I have seen a lot, and I'm sure Dr. Cox and others will see in their practices as well. Family and friends who have little knowledge or no knowledge are advising those persons who are. Remember, the family is your support system. Your close friends are your support system. You may not necessarily listen to the doctor or nurse, but you may definitely listen to your family and friends. So those persons' influence are also playing a big role in this. Financial constraint, I don't have to say much about it. Being sick is not cheap, even though government provides the free health care, but there are financial costs as well as other social costs, and everything has to be considered, and that's a very deterrent factor for persons who are coming to the facility with very late stage. And another one that we need to address from our side is the long await for biopsy results. That has been Does have been things in the past, but we still is. We are struggling to find the improvement in that regards. We are getting there, and we are going to get there at one day. And based on those factors, and we normally that majority of the persons we see at our facilities are present at a very late stage, unfortunately. So sometimes the radical treatment cannot be given, and we have to end up giving the supporting or palliative or the supporting treatment for those individuals. It's very unfortunate. So how do we approach this? I'm just using the simple methods and natural history of the disease. At one point, we all are susceptible, the stages of susceptibility. We don't have cancer, you don't have cancer, but we are being constantly exposed to carcinogens, or in this case, in this days and age, we are being constantly exposed to COVID virus, and cancer is carcinogens. So in that regards, we have to, from the healthcare providers, as well as personal responsibilities, to make sure that you are practicing healthy lifestyle. And we have to, from our end, the government as well as the health service providers have to give environment or condition where the persons can practice healthy lifestyle. So that's what we call primary prevention. So healthy messages, healthy, Jamaican movie is one of the examples I can think of right now. And after all of this, some of us are going to be end up having exposed to it, and we're going to be developing cancer. Before we reach to the sinus symptoms, before we actually have sinus symptoms of cancer, there is a stage where we call stage of subclinical diseases. So you have things going on inside your body, but there is no sinus symptoms. For breast cancer, in this case, if we can find it when you're having the pathological changes that is happening in your body, we can find it early. That is where we can cure you, we can treat you properly and effectively. So that's where we call secondary prevention. Screening should be done in the population. Screening should be done for the persons who are at high risk, and also opportunistic screening, where you see the male, female in that particular reproductive age group, the person is coming for other things, or hypertension or diabetes, and you try to give the opportunity, use the opportunity, and to provide screening for breast cancer. If she is not detected, she is not doing the breast examination, you do that for her, or you ask, or you advise her to do that. That sort of thing. So screening is very important. After all of these two stages, and some of us are going to end up with the cancers. That's where you are also, we have to be focusing on how can we manage persons with breast cancer effectively. So we have in the West, we have cancer, we have only 2 cancer sites in the government in this country. One is in Kingston, the other one is in KPH, Kingston Public Hospital, Kingston Public Hospitals. And we have the cancer center in the West, which provide cancer care for the people who are coming to us with any types of cancers. This is some picture from the primary prevention, Jamaican Move, healthy diet, and self-control. And this is one of the areas that I would like to emphasize. No matter how much others tell you, it is totally dependent on you. If you don't do it, there's nothing others can do about it. So personal responsibility is very important. We also look at the delay model when we strategize our preventative measure and management of those patients, and try to dissect what are the delay that we are seeing here. Patient did not recognize the problem, persons are not recognize the issues that they are having, the persons are delaying their healthcare for whatever reasons, and delay in accessing to our facility to the cost, transportation, community factors, etc. So using that model, identifying those factors, and we try to address them as much as we can. Of secondary prevention, again, talking to your patients, testing, and also examination of the breast. Another delay model is persons who are coming to our facility. Are we giving them appropriate care once they are in the institution? So this is in the institution between among ourselves, and look at what are the training that we need, the quality of care that we are giving, decision making, whether or not what type of treatment is going to be given to the patient, and what are the actions that we should be taking. The person should be treated in South hospitals or sent it to the cancer center in Cornwall Regional Hospital, or vice versa. And also other aspect of it, do we have any facilities to manage this case, or do we have facilities to screen these cancers? And we are just doing that in Westmoreland Public Health Services. I said that on previous presentation by way of doing it through primary care and secondary care. So if you are going to find out about your breast status condition, I would encourage to visit one of those sites or health centers in the public health facilities. But if you can go to secondary care as well, but as you can see, secondary care is for emergency and others, so you may not be able to get through right away. But I would encourage to go to your nearest health center and try to make sure that you screen yourself from breast cancer. And I will go into detail, but Jamaica response to the cancer, there are areas that we are addressing. We have a strategic and action plan by way of our vision is to reduce the cancer by 25% by 2025. Reduce the incidence of prevalence cancer by way of primary prevention, health promotion. That's where we are focusing a lot, and you can see a lot in the radio and other medias. We identify cancer that's affected screening, that's a secondary care. We are trying to improve that and improve the accessibility and availability of cancer care. And like I said, we have cancer center in Cornwall Regional Hospital. And not only that we have cancer center, we have to improve the quality of life by way of rehabilitation and supportive and palliative care that is given in the tertiary institution, and one of the tertiary institutions is located in Kingston. And cancer is not the easy test that we can manage. Now, we're not going to need doctors. We're also going to need different specialties to co-manage the patient, cancer patient. So we are now reorient our health sectors as to patient care assistants, social workers, and different kinds of supporting staff to support the cancer care in the cancer treatment. And we also need to improve the effectiveness of how are we doing, what different types of strategies and action plan that we are doing, how effective we are by way of doing the cancer research, and also do the surveillance. Due to the surveillance, I was able to produce or present some of them slides in my previous presentation. So in summary, this is the disease of premenopausal women, but also affecting the younger ages. This is the more cause of cancer, maybe due to the risk factors such as age, family history, estrogen level, and environmental factors. And we also need to be mindful about the fact that 4 in 10 women in our population self-breast examination they have never done by the doctor, but mostly done by the medical doctors or medical service provider. Fear may be the factor, that's why persons are not ended up going to the mammogram. And healthy lifestyle is the way to go, and personal responsibilities is also the way to go to prevent having cancers, including breast cancers. Thank you so much for listening, and I'm now over to Dr. Over.
Thank you very much, Dr. Ong. A very comprehensive presentation. We apologize to those of you who might have heard his audio coming in and out. Just some technical difficulties with the equipment. Quickly just to say that Dr. Ong has helped us to recognize, if we didn't know it before, how serious and significant a disease cancer is worldwide, but certainly here in Jamaica and in other spaces like Westmoreland. He also helped us to recognize how much there is that modifiable risk that we can take control of and do things about our alcohol consumption, our salt, sugar, lifestyle, being physically active and so on, helping us to recognize that some of what prevents us from going to do screening may well be fear, poor advice, and so on. And having heard and recognized that, all being well, from today's conversation, we can take some steps to move in the direction that will allow us to overcome those modifiable risk factors and the concerns with our lifestyle. And I would like to invite Mr. Archibald Peterkin, our first cancer survivor, to share with us his story. Mr. Peterkin, as you realize, is what you might call a strange bird because he's a man that's affected by breast cancer. In fact, he's a survivor of both breast and prostate cancer. And he's going to share with us a little bit about his experience, his story, how his faith in God has helped him to live through and to work through this experience of cancer. So, Mr. Peterkin, please share with us your story.
Praise the Lord. First of all, give God all the glory and praise. And I'm so thankful for you to have me here today and your program. Um, my experience with cancer, with the breast cancer, first of all, was very frightening because I did not know that men could have breast cancer. And when doctor told me that it was cancer, I remember I sat in his office and all I said was, my God can heal all diseases. And he said, excuse me? I said, yes. And we had a little talk and, finally we moved on to other things. And he said, in all his practices, he had experienced around 5 cases with men having breast cancer. Now it's a lot more than that. It has spread all over the place. But I decided to go to the United States and get it done. And because my children, they wanted me up there, so I went back to him and I told him what they said. And he said, well, the surgery will be the same, but the environment will be a lot different. And it was so true. So I went up there to get it done. But when I got, before I
I
got there,
apologize. Is there any way you can increase your audio? It's rather,
can you hear me clearly?
that's a little better.
All right. So the night before we went away to the United States, I was in the shower, and like I said, it didn't bother me for a while, but everyone who heard of it was really concerned. And in the shower, the devil came to me and he said, you're dead now, and you are this and that. And I said, wow. And I broke down in tears. That was the very first time. So I washed myself off, and I went into my bed, into the bedroom, and I knelt and I prayed to God, and I crawled up in the bed, and like since I'm talking, I fell asleep. I heard like the window was broken, and a light came through the window and sat on my chest like that. And I said, I got out of my sleep and I said, what's happening? I thought somebody had thrown a stone and broke the window. So I turned to see who did that, but there was no broken window there. And my wife came in the room at the same time and she said, hi, Pete, you're looking so bright up, man, what's happening? And I said, bright up, you're tripping, because I'm shaking. Anyway, she asked me, did you have the lump in your chest still? And I said, yes. And she said, well, I know you, God, and you work differently, which is so true. There's some other experience I had. But anyway, to cut a long story short, we went away to America the next morning, and I went to see the doctor, as I said, and the doctors started to look about it, and they saw the slides were broken. This was very unusual. The doctor said, how did this happen? We didn't know what to tell her. And then she said, they cannot do anything with me again because the slides are broken. They have to start the program all over again. And I said, okay, I'm in the right place. And they said, yes. So then they started the procedure and surgery took place and all of that. And the next thing I know, they said there was nothing there for me to get chemo or any radiation. The cancer had been gone because they showed me the cancer. This thing was like, had around 10 little sprangs on it and like was rooted up out of my body. So when I realized what happened, it was when I heard that the thing that broke and I thought it was the window in the house, it was the slides because the 2 slides got broken. And that's why they had to do the test all over. And that was my experience with it. And until today, going over 12 years now, I have not had any problems with it. I go back for a test time and time again, and there was nothing. Then as time went by, I had the prostate cancer. And something like that happened again in a similar way. And I didn't get any chemo or any radiation. And both of them come together now totally for 14 years. And I'm still here just praising God and encouraging people that God is still the answer for all of this stuff. So we should really focus on what the doctors are saying and follow the instructions, but we must put God first as our main source of supply in everything that we do.
Amen.
Amen.
Amen. Thank you very much, Mr. Peterkin. That is such a powerful story of faith and how the faith that you have in your Creator has carried you through and helped to be a part of your process of healing. Thank you very much for sharing that part of your life with us.
It was more detailed, but Miss Dorothy asked me before. She said, she only gave me 2 minutes, I think. So I must not go too far into it. But she know the whole story already. She maybe can share it with you some other
Yeah,
time.
man. And in fact, I'm sure that one or two people will want to engage a little bit more when we come to question and answer, because it's very powerful to hear how God has worked in your life. And many people want to hear stories like that so that they can experience and ask for the same thing for them. So we do appreciate your sharing with us.
That
Thank
is,
you.
that is everything here. Trust me. I believe me. She herself knows too, as one who survived and put her trust in God, and He's working for her along with medication, because He's still the author and the finisher of everything. So we all have to remember that we must put our trust in God and do what the doctors say, and we will be all right. Because I'm
Thank
as
you
a
very
living,
much.
as a living testimony, I'm right here.
Much appreciated. All right, well, we're going to follow on Mr. Peterkin's testimony with another testimony. We're going to ask Nurse Nicole Smart, and she's also a cancer survivor. Nurse Smart is a midwife practitioner, and she's been a registered midwife for the last 14 years. She's a woman of God and a woman who loves to serve her community and serve her profession. So she's also JP. She has been the first vice president of the Jamaica Midwives Association, and she's also the former president of the Manchester Midwives Association. And she was diagnosed with breast cancer in 2013 when she was 40 years old. So she has quite a story that she'd like to share with us as well. And so I'd like to invite Nurse Smart to share her testimony.
Hi, good evening. Hello.
Good evening, Nurse Smart. We're hearing
Okay.
you.
Okay. I'm Nicole Smart, as you previously said, but one clarification. I'm a midwife, not a nurse. So
How do we
quickly,
address midwives? We don't say
sorry?
nurse? But how do we
No.
address? Do we just say
Um, Nurse
sister?
midwives are different from midwives. I'm a directly trained midwife, which is
Okay,
different.
which is
Hmm.
different.
Yes.
Okay. Clarification appreciated.
Okay. My quick little 2 cents. So, as a midwife, I do, apart from delivering babies, we do immunization, we do pap smear clinics, we do the antenatal clients. So, I normally have severe migraine headaches, and I was always saying if I'm ever going to have cancer, it would have been a tumor in the head. There was a day when I did a pap smear clinic, and I remember I did 15 women, and out of the 15, only 5 had done the self breast examination. So I was saying to a colleague of mine, why don't women practice the self breast examination? And my colleague said to me, they don't. Do you? And I said to her, no, I'm good. And she said, no, we really should do it. So I said, no, man, I'm good. I remember going home, having a shower. While I was taking off my clothes, this little voice kept saying, you need to examine the breast, you need to examine the breast. I ignored it. I had my shower. I dried off. I was about to put on my clothes, and the voice kept telling me, examine your breast. So I did. I did the left one and I'm good. I did the right one, and in the middle of it, I felt a lump. So I was sort of taken aback, and I'm like, this is a little lump. I looked at the calendar and I said to myself, okay, it's ovulation. So I'm not going to be concerned. This was in February of 2013. At the end of the month, period gone, the lump is still there. March, the same thing happened. In April, I think it was early April, I was at work one night. I work in the evenings with my gynecologist, Dr. Duval. And I said to him, at the end of the night, I said to him, I think you need to examine my breast. So he asked what was happening. I told him there was a lump. He did, and he didn't say anything. He walked out of the room. When I came into his office, he was on his phone. When he got off, he said, I had an appointment with the medical practitioner. So I was asking why. He said, because I'm going to need to do an ultrasound and maybe a mammogram. So he's sending me to somebody else. So he sent me to Dr. Baker. I went and he examined, and yes, he did send me to do the ultrasound and the mammogram. Now, in my mind, mammogram was for old women. Even though we're told at 35 you do your mammogram, I wasn't thinking of doing any mammogram. But I did what they told me to do. At the end of it, the results came back that I needed to do a biopsy. Now, Dr. Baker went ahead and made the appointment for the biopsy. However, on the date that he chose, I had annual general meeting and I decided I wasn't going to miss it. I was going to Portland. So of course I did miss it and I went to Portland and I had fun. I came back and I made another appointment. I did it and I was told the result will be back in 2 weeks. So I went about my business as usual because in my mind, something going on, but no, not cancer. Within a week and a half, I was called. When I went in, doctor was talking to me and he was talking about little things and going around. So I said to him, what is it? Tell me what it is. And he said, I have good news and I have bad news. So I said, give me the bad news. He said, the cells are cancerous. So I got up because as far as I'm concerned, I'm dead. He said, where are you going? So I said, I have bad news. There cannot be any good news. I'm leaving. He says, no, sit down, Nicole. I sat down. He says, the good news is that it's at stage 2 and with mastectomy and chemo, you could live for a couple of years. And he went on. And he was just, I was trying to process it, but this couldn't be real. So he was telling me, and in the middle of it, I looked at him and I said, you're really annoying me. And I got up and I walked out. I went back to work. And then the next day I went back to him and of course I had to apologize, but he understood. I was told that I need to do a mastectomy and then I need to do chemo. Fortunately, I was in good hands. God knows best. Between Dr. Duval and Dr. Baker, they sorted me out. So I had surgery on 24th of June 2013, and within 6 weeks, I started chemo. I did most of my course. I didn't do all of it. I did most of it, but I changed my diet. Well, yes, for quite a while. I did change my diet and I have been going on. I have been praying. I've had a lot of support, and that is one of the things that kept me the support. I am still here. I am going on, and I'm here to help whoever I can in whichever way I can. Now, this is my little bits. You can pass on all the questions. I'm willing to answer. Thank you.
Ms. Pat, thank you very much for such an honest and open account of your experience as a professional. And it strikes me remembering something I learned from the last teleconference as well. Many people may be joining who had been on that presentation as well, that there seems to be something about professionals not wanting to get their own tests done. And we'd love you to process that with us a little bit later on so that we can help you and that you can help us. But we thank you for sharing that journey and the joy of having you with us and just the joy of your countenance as you're sharing that story with us makes us smile and so grateful that you continue to be with us. So we'll talk a little bit
Thank you.
later on.
Okay.
All right, brilliant. I'm now going to introduce Dr. Lincoln Cox. And Dr. Cox is a general and vascular surgeon who practices at the Savannah Lamar public hospital where he's head of surgery. And he's also head of surgery at the Royal Medical Hospital in Westmoreland. You would have heard Dr. Ng mention that hospital, private hospital, several times. And of course, he's a lecturer at the University of the West Indies, so you know he has to be among the best. Dr. Cox is going to speak with us about younger women who have developed metastatic breast cancer. He's going to talk to us about the factors that may be underpinning this increase and how we're being called upon to respond to these. So Dr. Cox will speak to us for about 20 minutes, and then we will move on to another testimony of someone that has survived cancer. So Dr. Cox, over to you.
Okay, thank you very much. I'd like to share screen here. In the meantime, while I'm sharing, I'd like to thank the MistyBlue Cancer Care Society for this ongoing work with cancer. We're happy that they're making this effort. I know Dorothy Satchel very well. She called my phone every day. And she's a very, very, very hardworking woman in this challenge of breast cancer in the parish and in the region and in Jamaica. I think my work is made a little bit easier today because Dr. Ong has presented a lot of the statistics associated with breast cancer and showing the trends, giving some of the reasons why we have breast cancer and some of the risk factors. So my input shouldn't be that long tonight. Thank you for the introduction. I see most of the breast cancer patients at the Savlamar Hospital and operate on them along with my team, a very hardworking team at the hospital. Now, I want to start this presentation by looking at this picture. This is one of the first patients well, not the first, but one of the very interesting patients I came across during my residency at the University Hospital of the West Indies. This is a lady, and she gave me all the permission to show these slides. I have a painting of her right above my desk. She's Viv Logan, very interesting lady, was an advisor to the Prime Minister in the 1980s, and showed this very interesting self-portrait. She's also an artist, and this self-portrait showed her artistic depiction of breast cancer. I thought it was fascinating. And I have this painting right over my desk at home. Unfortunately, Viv Logan also, she beat breast cancer and survived for many years later, eventually developed rectal cancer. And I think she just decided to throw the towel in at that time. Now, a lot of this of what is breast cancer and so on, we won't go over. But just to reiterate or to emphasize, it's the leading cause of cancer death in women worldwide, and the leading cause of cancer death also in Jamaica. So it's a heavy, heavy burden that we face with breast cancer in Jamaica. So for every 21 women in Jamaica, one will develop breast cancer. In the USA, 1 in 8. So the incidence is higher in the United States, but we'll go on to, we will see later on where even though the incidence amongst Caucasians may be higher, fatal outcomes are worse amongst different races, and certainly the Blacks have a higher death rate. All right, won't go through this one. However, we're going to look at this. This is a picture, and I like to show pictures in surgery. I like to take pictures and videos. It's a picture of a young female with breast cancer. This is a picture from the University of the West Indies during my residence, one of my patients. But she had an interesting type of breast cancer. This is called an inflammatory type breast cancer, and treated accordingly. Now, just to say that if you feel a lump, see your doctor right away. most breast lumps are not cancer. And my message to women, because I've seen young women, old women, all different ages, and the underpinning factor with lumps in the breast is fear of breast cancer, fear that it's a big C, when most cases of lumps in the breast are not cancer. However, it's a good idea to have all these lumps checked out. So you can, most women, I want the message is most women in Jamaica can feel safe to say that if they have a lump in the breast, it's unlikely to be breast cancer. However, you must check this lump out. Some old statistics here from the task force in Kingston that looked at the incidence of cancers in Jamaica, headed by Dr. Blake, Dr. Blake at the Cornwall Regional Hospital right now, and Barry Hanchard, the late Barry Hanchard, etc. 99 statistics is old, but this trend remains the same as Dr. Ong had shown, that amongst females still, breast cancer is the leading cause of death, cancer-related death in females, followed by the cervix and then large bowel. And if you look overall at male and females, as we had last month, when we looked at prostate cancer by far the leading cause, and then comes breast cancer. Breast cancer is a sensitive topic in Jamaica, and so deserve the attention. If we look at the age distribution then, because we're coming around to looking at why is it that we're seeing a lot of patients, younger patients with breast cancer. However, it's not a strange thing, because when we look at this age distribution bar chart here, again by the Cancer Task Force in Kingston and it's the St. Andrew Group, this data is coming from, we mostly find worldwide that most patients with cancers are usually in their mid-50s and above. However, when we look at Jamaica, we're looking at distributions, the percentages, very interestingly, in the young age groups. So usually breast cancer, we think of the young patient as a patient below 50. Lots of people address younger or young, or define it as 40 and below, but under 50 for breast cancer is young. So we've seen a distribution, 12.6% 30 to 39 age group, 18.7% in the 40 to 49 age group. So if we add these up, we're going what? 1/3 of all the cancers that we'll see in Jamaica are in patients who are young. Then we get to the typical age group, where we get now this age between 50 and 69. Guess what? Another 1/3 here, right? Almost another 1/3. And then we're seeing more, just a bit over 1/3. And then we're seeing a lot of older patients with breast cancer as well. In the United States, breast cancer in the young, they describe young as less than 40 years. They have incidence of, greater than 1,000 deaths per year in this young age group. And it's not capturing that age group that we also consider young, between 41 and 49. At the South Lamar Hospital, briefly looking at my own personal data with surgeries in breast cancer, so far this year, I'm looking at a 1-to-1 ratio between young and the normal age group. So my young age group are patients who are less than 50, or most of my patients who are considered young are below the age of 45. So we had 8 patients in 2020 so far in the young group that had with the mastectomies on at South Lamar Hospital, and the typical or the normal age group 8. So it's 1-to-1 here. When I look back at my data, because I log all my cases, in 2019, we had 9 young versus 11 of the typical age group. So we're seeing almost a huge rivalry now between those who are young, almost the same ratio, and the typical age group, when the international incidence is showing that the majority of patients who would be more Caucasians are usually the older type patients. Now, what's happening with these younger patients? They tend to be diagnosed at a later stage. And that's one of the problems that we have, because fear, I've always said, is driven. They're driven by fear and they stay away. And so they present later. They tend to watch it. They tend to hope that it will go away. Sometimes they tend to listen to other people about what to use, what to do, who to go to, and then they present late. I've had many cases of patients who present and represent because of sometimes how they're being influenced in the wider society. Culturally in Westmoreland, we find that the patients will listen to older relatives, older adults who have advice on these issues, especially when it comes to a fear factor. If they're afraid of going to the doctor and have that diagnosis made. What's the problem though? Because in the younger age group, the tumor is more aggressive, meaning that it will spread faster and your survival time is shorter. Most surgeons will know or knows that when a patient is diagnosed with breast cancer in the elderly age group, right? Those tumors are they're not very aggressive, and in the elderly, patients who are diagnosed in their 80s, late 70s with breast cancer tend to meander with the tumor. The tumors tend to stay there, and sometimes not as aggressive and not as fatal as if in the younger age group. So because it's more aggressive, you get a higher mortality rate, right? And once it's more aggressive, there's a higher risk of metastatic cancers in those patients. So you have metastatic disease at presentation, and you can have metastatic recurrence if they have a recurrence of the tumor. Now, what are some of the challenges in the young? The problem with the younger patients, apart from we knowing all these facts, is that there's no effective breast cancer screening tool, because we know that the gold standard, when you look at the standards for screening, that mammography is the gold standard as a screening tool. However, the challenge we get with mammography in the young is that it's not very sensitive, because the breast in the young is very dense, and dense breast does not show up very well on mammography. The other screening tool that we have that we could look at in patients who are young and also patients who are high risk for breast cancer, as Dr. Ong has highlights, what are some of the features of being a high risk young person? One of them is a family history, right? A strong family history. And then you will, with the possibility of getting a hereditary disease or having one of the genetic syndromes. However, the other screening tool that we'd use in a young is MRI, magnetic resonance imaging, which is, again, we know is not readily available to all patients. And even no matter where you go, it's very difficult to get an MRI, and also a costly event. And look at the statistic here. Breast cancer is the most common cancer diagnosed in pregnant women as well. And I have a patient, I have many patients, but I have one right now in my clinic who is, I'm in discussion with a gynecologist, obstetrician gynecologist, in terms of her care, because she's 8 months pregnant and have a very aggressive looking mass in the breast. 3 weeks ago, it was a 3 centimeter lesion, and now it's about a 6 centimeter lesion, very aggressive. And 30% or more of breast cancer diagnoses occur just after birth. And as we said before, the incidence of metastatic cancer at diagnosis at the age of 40 or in the young is rising. And so for all these factors, one, more aggression, aggressive tumors in the young. It is diagnosed at a later stage generally for whatever the reason is worldwide. But we understand some of the factors in Westmoreland and in probably Jamaica about fear and about the role of the community sometimes. And hence the role now of more health promotion within the community is necessary in order to educate those around us who these younger patients are taking advice from. So unfortunately, we show these terrible pictures, but when it hit us, these pictures hit us regularly in the accident and emergency department, in our clinic. And even though this patient may look like a old patient, this is a very young patient with a very aggressive and very, very end stage disease. So what are some of the challenges in the young, and who are we seeing, and how may the young present? I mean, Dr. Ong mentioned the fact that the strongest risk factor you may have is a family history. And a family history may mean that you have now a hereditary type syndrome, some kind of genetic, some genetic compromise that may now make you at higher risk of getting breast cancer. Now, the commonest thing we see worldwide in terms of breast cancer risk factors in the young and in terms of more aggression of the tumor is this gene here, the BRCA gene 1 and 2, right? For those who are who like movies, Angelina Jolie had this BRCA1 gene because she had a very strong family history, and then she went on to do prophylactic mastectomies. But BRCA is certainly one of the most common, and I've come across BRCA in Westmoreland by chance. I had a 32-year-old patient in 2015 who presented to me with stage 3 breast cancer. And I just thought this was just, yes, it was an advanced stage tumor. And I was really up in arms as to why she waited so long. However, we attempted to do neoadjuvant chemotherapy that didn't help, and we had to move very quickly after a few doses for her having a mastectomy. She had a mastectomy and she was 40 well, and she eventually went away because her mother lived in New York, and she went to New York and found out that she was BRCA1 positive. Fortunately, for a few years, she got into a Pfizer trial there, looking at the PARP inhibitors. She was being given those PARP inhibitors, and she survived for another 4 years with metastatic cancer to the vertebral column, to the brain, and so on. Interestingly, this 32-year-old came to see me at age 35. Somebody's mic is on. At age 35, when she was on these PARP inhibitors from Pfizer, and she was doing very well. Unfortunately, the load of her tumor was too great, and she passed away in 2018 or 2019. But what are some of the other genes associated with may increase your risk of breast cancer? And these are what I call the invisible enemy, or the invisible factors, the factors that you can't see, right? Having these genes, BRCA1 or 2, ATM, that patients who have ataxia-telangiectasia, the P53 gene associated with Li-Fraumeni syndrome, and others. These genes increase your risk of having breast cancer, and increase your risk of having breast cancer at a young age, ages in your 20s, in your 30s. We had mentioned other things before, apart from that, the family history, as we said before, personal history, history of obesity increases the risk, alcohol use, etc. are other social factors that increases your risk of breast cancer in the young. Now, when you look at these hereditary and genetic factors, you wonder, how do you challenge, or how do you unearth these hidden dangers? How do you get at these mysterious hidden factors that tend to affect our society so greatly with this burden of disease? And if we have one patient in Westmoreland who somehow went away and is found to be BRCA1 and 2, BRCA1 positive, then you can rest assured that we have a lot more patients in the parish and in our environs that have these genes circulating with breast cancer. So we see a patient in their 20s with breast cancer. Really what should happen is that they should go for what? Genetic counseling and testing. They should be. Problem is cost here, because I'm aware that there is genetic counseling and testing going on in Kingston right now, but in order to get a sputum or a cheek sample or even a sample of the tumor to get there, the cost to do these genetic panels, because when they do it, they're not only doing BRCA1, 2, they're looking at a lot of these gene syndromes to see if they are positive. And the cost, I think last time I checked with the oncologic surgeon in Kingston, I think it was $60,000 to do genetic counseling. But it would be important, and I think when we discussed this many times at meetings, and we thought that with the high incidence of breast cancer in the parish, I know that there are other diseases such as high blood pressure, diabetes, and so on, and other cancers as well that affects our population. But if this would need a sponsor in order to get to doing genetic testing amongst our young patients with breast cancer. And there are challenges then, because I see them every day amongst the young with breast cancer. The possibility of early menopause and sexual dysfunction are huge issues that occur with these patients. There are fertility issues, the burden of raising young children while being treated for breast cancer. And we have a unique situation in Jamaica where the household is not a lot of single mothers. And I've seen so many single mothers who bring their 5-year-old to the clinic, and they're being treated for breast cancer. They have to do surgeries, they have to find someone to stay with a child, etc. And these are real challenges. There are also psychosocial issues like depression that occurs in these patients, and the anxiety associated with it. Later on, questions in young patients who develop breast cancer and treatment develop about future pregnancies, and we have to advise them that one of the things about pregnancy and breast cancer, they don't go together, and certainly it's something that is challenging if you think that if you get pregnant with a syndrome or a history of breast cancer, then you might increase your risk of getting breast cancer again. So that's a challenge. What about body image after surgery? You have intimacy issues. I've seen so many patients who lack financial stability in terms of investigations for surgery, because while the government does offer chemotherapy, and there's a setup in Cornwall for chemotherapy, neoadjuvant chemotherapy, radiotherapy. But the preoperative analysis of these patients before surgery, a lot we don't take into consideration. Most patients are going to need an echocardiogram before chemoradiotherapy. They're going to need a CT scans and so on. That's not readily available if you are not admitted to the hospital in our current setting. And so these patients tend to have to find there's a financial challenge when trying to even prepare for therapy. And sometimes even preparing for surgery can be a challenge. And so you find that a lot of the patients, apart from just presenting late, you'll find that they delay their care trying to trying to get these tests prior to treatment done, and that's a huge problem. And a lot of times at Savlamar Hospital, we know what the protocol is for management of patients with breast cancer. We know when patients are young and they present with advanced breast cancer that these patients need neoadjuvant chemoradiotherapy prior to surgery. But we also know that this young woman who presents to us is not going to undergo any chemoradiotherapy with financial instability. And we have had so many patients that we have sent for neoadjuvant chemoradiotherapy assessment. And when the assessment, when the assessment is being done, because there's a cost to it, you find that these patients are lost to follow for months. They're waiting to do an echo, they're waiting to do a CT, they haven't done anything yet. They're waiting for the resources in order to do these things. And sometimes, even though we explain to them, the patient, out of fear, out of a lot of things, will go home and wait for these finances, and then months will pass, and when they present at a higher stage because of financial problems. Race, we know worldwide, yes, Caucasians do get breast cancer at a higher incidence, but in Blacks, African Americans, the tumors are more aggressive, less aggressive in Latinos, Asian, and so on. But for Blacks, it's more aggressive, with increased rates of death, and they're more likely to carry a higher financial burden as well because of their socioeconomic status. And these things contribute to the higher death rates amongst Blacks. So are these patients now with young patients who will present with breast cancer? Is there a test for breast? Yes, there's a mammogram, but of course the mammogram offers this challenge. And you do a mammogram, it's probably too dense. You do an ultrasound, and then you probably have to move to do an MRI, and that has the burden of a financial cost. Again, that's a tumor. Now, we stage the patients once they come in. It's a way of saying how far the cancer has spread. So once we see a patient, young, old, wherever, with breast cancer, we make the diagnosis usually through a biopsy. We have to get tissue, usually a core needle biopsy. We get some tissue, we send it to the lab sends us and say, yes, there are mitotic cells, etc. And the patient has breast cancer, whether it's invasive or in situ. And we now have to determine how far this thing has spread. And here again comes a challenge of cost, because spread, for distance spread, we usually do, sometimes we can do just a chest x-ray and an abdominal ultrasound. A lot of times, to be more accurate, it requires a CT scan of the abdomen and the chest, which again can be costly, can be difficult to get, even through the hospital system, can be difficult to get. We operate on these patients because breast cancer is a surgical disease, and their patients are treated in many ways. This forum is not one to talk about what types of surgery, but the majority of patients will get a mastectomy. They will remove the breast because of challenges with the other procedures like breast conservation surgery, otherwise called lumpectomy radiotherapy, or skin spray mastectomy, etc. Not to mention the reconstructions that can occur along with mastectomy surgery. Mastectomy removes the whole breast, and there's a reconstruct, and you can reconstruct it after that with a plastic surgeon. But a lot of times, depends on the patient, depends on the stage. This is not advised. Again, as a surgeon, we tend to do, well, we're not going to see that, but no, we're not going to see this. No. Okay. All right. So breast conservation is possible with these problems because we don't easily get radiotherapy, which accompany, which is a mandatory part of the treatment with breast conservation surgery. And the wait time for radiotherapy is usually anywhere between 8 and 10 months when we need the radiotherapy 6 weeks post lumpectomy. Of course, whether we do conservation surgery or we do mastectomy or we do neoadjuvant chemotherapy, these radiation and chemotherapy is a mainstay of treatment of breast cancer. Hormonal therapy follows in these patients. And then we have to monitor the patient for recurrence, because most patients who have breast cancer, microscopic tumor cells, isolated tumor cells are spread, can spread. And even though we give chemotherapy, and that's a role of chemotherapy, to mop up all the microscopic cells that may have spread to far areas in the body, they still can have a recurrence. What happens if it comes back? We treat the patient the same way. We assess the patient for whether possible second surgery, chemotherapy, radiotherapy. Can it be prevented? Breast cancer, certainly, you can prevent it in some ways. Not going to go through the details of that one, but if you do have, for example, BRCA1 gene, there's a role for prophylactic mastectomy. You can take off the breast. If there's no breast cancer. Most people with early stage breast cancer must qualify here. Most patients with early stage breast cancer do very well. The cure rate is greater than 95%. The problem is, if you stay out there with a lump for too long and it becomes an advanced or late stage breast cancer, then the cure rate is not very good. And so most people with late stage breast cancer don't do very well, but early stage cancers does very, very well. And we encourage all males, females with a breast lump to come in early once you feel the lump, because that's the time to treat the lump. And the first time you recognize it. Some choices that we talk to the patients about. You can do your own breast screening at home. You can do self-breast examination. And the goal is always to get what, if it is, this lump is there, you get it for the first time, it's early. Most of the times, once you feel a lump for the first time, it's early. How do you check? Just quickly, just going through self-breast examination. You need a mirror. 1 week after the period. Otherwise, you can do it at any time. First, you observe. Take a look in the mirror. So what you're checking for? Asymmetry. One don't look like the other one bigger than the other one darker than the other one, etc. And you note those things, and then you're gonna feel. It's one lady with discharge from the nipple, and this is one obvious look. One clearly the right breast is much bigger than the other one. Something is wrong here. All right, left hand to right breast. Opposite hand, opposite breast. Start with small circles with 3 fingers. To make it nice and smooth, you can go in the shower. And to more detect lumps better, you can go in the shower and put some soap on the breast, lift one hand up, use opposite hand, opposite breast, and just feel the entire breast. And then in the shower with the water, with the surface tension is less, you're more sensitive in terms of picking up a lump. Thank you very much. I think I've gone over my time.
Dr. Cox, I know I'm supposed to say thank you. That was a very sobering presentation. And for someone like me, it was also one that made me extremely squeamish, looking at the very raw pictures that you shared with us. But I have to tell you, thank you very, very much, because that sobering presentation, I think, jolted me and perhaps several others of us who listened to you as you really brought home to us the significance of this disease, the genetic factors that can be at play, and whatever the factors are, to recognize how aggressive it can be among women who are below 50, and how you're seeing more of that, and the aggression of it can be even more deadly. But even beyond the impact on the body of the woman, this significant disease has other troublesome financial and fertility and child rearing and body image concerns. I think we really have to take account of in a way that perhaps we hadn't before. So thank you so much for sharing. I think there are many questions that are going to come your way in a short time. Questions have already started to come to us from Facebook, and we'll share those with you as we go along. But thank you again for a very sobering presentation that I think has jolted many of us. And I, having said that, would like to invite Dr. Sophia Longmore. She's a government senator and a well-known psychiatrist. She's herself a cancer survivor, but Sophia prefers to call herself a cancer thriver as well as a cancer survivor. So she's going to share with us her own story, following on from Dr. Cox's very, very sobering presentation. Dr. Longmore, please share with us.
Hi, good evening, everyone. Thank you so much, Anna. Yes, I can appreciate and thank you for having me on in this very useful and pertinent forum at this time. I think we're all absorbing the reality that Dr. Cox shared and some of what the other presenters have shared. And I know it all too well and can relate to it. And Dr. Cox, it's no shocker to me, but I can understand also the reason why it could be so jarring. And maybe sometimes that is what we need, because that is probably what brings the reality to us all as to what it is that we're dealing with. I myself, as many persons know, I was diagnosed with breast cancer on October 2nd. Well, I shouldn't say that I was diagnosed, because I found the lump on October 2nd, 2017. And this October 2nd gone makes 3 years. I went through a whole gamut of treatment. I went through 26 rounds of radiation, 24 rounds of chemotherapy, 3 major surgeries, including a double mastectomy. And I am grateful that I am able to actually be here to share my story. But my perspective is a bit unique, admittedly, because when I found the lump, I had been a medical practitioner for almost 20 years, and it was a shocker to me. I led a very busy life. I still do to some extent, but I was going about my regular daily activities. I was getting ready to go. I am a lecturer at the university hospital, and I was getting ready to go do my ward round there, and came out the shower and basically was toweling off. And immediately I felt the lump. I knew, because the training kicked in. And if I was examining a patient and I felt this thing, I would know immediately that it would be a cancer. And I remember I looked myself in the mirror and I said, I have cancer, immediately. And in that moment, it is in that moment of appreciating that you're going to be facing a battle for your life. It is almost as if I just went into, okay, let me absorb this, and then let me pursue what I need to do. And that is the message that I try to get across to people. This is why I went public with my diagnosis, It was not a matter of just being out there, PR, whatever. It was a matter of saying to people that, look, me in my capacity, being a medical practitioner for a number of years, with X amount of years of experience dealing with all sorts of illnesses, found myself to be having cancer because of my very busy life and because I wasn't doing my yearly checks and because I kept putting things off that I should have probably put on the front burner. And my message was, go out there and get checked. Find the time, whatever it is that you are so busy doing. When this hits your door, everything else is secondary. And if you are able to early detect, that is what may save your life. And so in that moment, my very initial situation was, okay, let me absorb this and then let me take control of it. And that may be, it may be easy to probably say, but not easy to relate to, because in order to take control, you have to have the mechanisms that are there. Now, we all say prevention is the best cure, but what is the best prevention? Preparation. And in preparing yourself for some of these unforeseen things in life, you have to look at the different dimensions of your health. You have physical health, you have mental health, you have social health, and you have spiritual health. All four of these are critical when you're dealing with a life and death situation. Your physical health, the diet, the exercise, the healthy practices, the immune boosting agents, such as the fresh fruits and vegetables that you would incorporate, watching the weight gain, etc., taking control of your physical health is critical. Your mental health, there's no question. One of the most, I remember when I sat in my oncologist's office and talking with other patients and also to the oncologist, very, very, very competent individual. She related to me that one of the most significant factors that seems to be associated with the cancer diagnosis is stress. And therein lies a significant effect that we tend to overlook. We always hear about it, but we have to manage the stresses in our lives. We have to manage the interpersonal relationships that may not be as you want them to be. We have to manage the financial situations that we may come across, the stressors. We have to actively seek ways of managing stress in our lives and our own mental health. That is another benefit of exercise. It helps you to be in a better state of mind. Another dimension of health is your social health. And a lot of people don't really focus on this, but this is where you have, and we break down social health. I'm also a psychiatrist, so this is kind of my forte. You break down social health on 3 dimensions: intimate partner, family, and friends. And these issues, where they are tumultuous, these interactions can impact on you subconsciously, can impact on your immunity. And it all boils down to basically that immune reaction that your body is supposed to be doing being out of whack. And so these social interactions, your social health, your ability to connect to people. I did not realize that when I went public with my diagnosis, in the effort to garner persons to go and seek out their own health, that it would be beneficial to me socially. Because I got such great response and such great positive energy that I knew that if I felt down and I was going through a rough phase of the chemotherapy, all I had to do was sometimes just look back at some of the posts and some of the responses and some of the encouragement. So even in the times when social interaction can be difficult, if we use the mechanisms that we have, it could greatly enhance our capabilities. And of course, spiritual health. Mr. Peterkin opened up with that. And there is no question that that is of a critical nature when we are dealing with our life and the possibility of the end of that. You realize that you're on a path, you're on a journey, and this is your own journey. And you question your existence. You question exactly what role you play in this world and how you can impact on such. And you recognize that you have reasons to maybe push and fight through because maybe your journey isn't done. And that is a critical aspect of preparing yourself for when you have these unforeseen battles that you might have to face. There are a few more technical things that I probably will get into a little bit here. And just to kind of break it down a little bit, a cancer is any rapidly growing part of your body, any part of your body. And that's why a cancer can happen anywhere. So if you get a cut on your hand and that healing process, that is what basically is responsible for cancer anywhere. The body's natural ability to repair itself. And a cancer is when that growth and repair process goes out of control. And so it can happen in any way, any form, and no two cancers are the same. What we have recognized now, and thank heavens we're in the era of medical expertise, where there are many possible treatments that are out there for the various forms of cancer. But not everybody can afford it, unfortunately. And that is why the message of early prevention is so critical, because the expense associated with treating the more severe forms is sometimes unsurmountable. Unfortunately, some persons can't afford treatment at all. And so they opt for more alternative forms of treatment. I am not going to knock it because I cannot know. I have never walked in those shoes, and some people swear by it. But my advice is to make sure that your body is able to handle some of these substances that persons may encourage you to take when you're in such a very vulnerable state. These things can affect your liver, they can affect your kidney, they can affect your blood, they can affect your heart function. So you have to be very careful of some of these bush medicines that persons, and like I said, I'm not going to knock it because a lot of our medications are derived from our goodly plants. But if you're going to go the road of formal medical treatment, which I did, like I said, I went full blown with that. You have the chemotherapy, you have the radiation, you have surgery. Now, again, no two cancers are the same. So what protocol may apply for one person may not necessarily apply for you. But you must stay informed. And whatever process it is that you're pursuing, decide on it and then just channel the positive energy that it will work. You have to know that you are going to win this battle. And for me personally, there was no doubt in my mind. I took control of that situation. When people are in a very dire state, when they seek help, is when they feel like they cannot control a particular situation that they have found themselves in. And that is why it is critical that you put the necessary things in place to prepare yourself for any eventuality. Now, in terms of just a little bit of the specifics, one of the key things that I found with chemotherapy is that I hydrated throughout the process. I made sure that I was drinking while I was getting the chemo, drinking lots of coconut water, making sure that I was warm, making sure that I was comfortable. These things may seem trivial, but it is very critical that you ensure that you're comfortable, because the entire process can be very, very daunting. When it comes on to the radiation can be very, very tiring. And at this time, you know, I still say to persons that when you're in the active process of treatment, if you feel like having an ice cream, have an ice cream. Your body is dealing with so many strong chemicals. You have to treat yourself almost like an egg. And if that is what makes you feel good and makes you feel like you can get through this process, do it. But you don't indulge in it. It's a different diet process after you have finished your treatment, because now you're basically focusing on not getting a cancer again. And that is now when you get really very rigid with diet, etc., etc. But during the radiation, the burn can be bad. The effect of the fatigue, etc., can be really very bad. So you need to supplement your body with the things that it may need. With regard to the surgery can be very, very painful sometimes. The healing process, you need to ensure you have time to rest and to recuperate from that. Now, the other little aspect of this, I won't go on too long because I know that we have another presenter or two afterwards. But I said this in my presentation in the Senate last week, and it is really very critical, because with all of this talk of healthy living, screening, etc., etc., you have to try to secure good insurance. At the end of the day, it takes cash to care. Dr. Cox basically highlighted some of the very grave cases that he mentioned in terms of the dire need for the economics and the financial support that a lot of cancer patients are lacking. And unfortunately, this lack can result in persons not getting the treatment that they need and actually succumbing to the cancer. Insurance is critical. It can make the difference between you being able to afford the medication or not. And so in all of your financial planning, in all of your preparation, it is critical that you factor in your insurance and securing such. There's absolutely no question about that. The last thing that I want to just kind of highlight is some of I mentioned stress being a possible factor in terms of the causation of the cancer. And there are many, many, many different causations. But I'm going to relate that I have no genetic, I did the BRCA testing that Dr. Cox mentioned. I don't have a family history of it. No family history of any breast cancer. I was BRCA negative, BRCA 1 and 2 negative. I did the entire range of genetic testing. No cancer genes. But for me, there's no question that my cell phone, I think, played a role in the causation of my cancer. And I'm underscoring that this is my personal experience. I had my children. I have 2 little boys, and I had them very close in age. And so I was up late at nights breastfeeding, and then I went into potty training. So for a period of about 3 years, I had late nights, and I would fall asleep. You know, you wake up, you do something with the baby and so forth, and you're not fully ready to go because you're now up. You're not fully ready. You go back, you go on the phone, you're doing stuff, whatever. And I would fall asleep sometimes with the phone right there, right beside that breast. And lo and behold, that's where the cancer came. But the way that I recognize that the cell phone has an effect is that even if I want to have a good, solid night's sleep, it makes a huge difference if the phone is within, say, 4 or 5 feet of me. I actually have subsequently bought a radiation-safe phone a radiation-safe case for my cell phone, because I have to use my phone for work. If I could do without it, I would actually do without it. But I am saying this to say that sometimes there are factors, and I kind of had an inclination that this wasn't a healthy practice. But sometimes we are going along our daily lives and we're not paying attention to that little voice that is telling us something, that is trying to trigger something in our mind to act, and we keep ignoring it. Listen to that little voice. Listen to that intuition. Listen to that, as we'd say in Jamaican vernacular, your mind tell you something. Yeah, because that may be just your subconscious, just your body actually trying to talk to you and trying to relate to you that something isn't right. Yeah. Now, at that, like I said, I did not want to go too much into the technicalities of it. I know that there was also a curiosity around my role, probably in the government, with respect to Jamaica's preparedness for some of the issues of cancer that we're dealing with breast cancer. I mean, I'm happy to say that there is a new mammography machine up at the University Hospital that is probably one of the most sophisticated in the region in detecting the early changes for cancer. And so if you are screening, that is definitely a place that you can get the most accurate reading. We have expanded chemotherapy sites at St. Joseph's and out in Cornwall Regional Hospital, and hoping to do one in central Jamaica. One of the great deficits, and this is why this effort by the MistyBlue Foundation and by the persons who are involved here are so very critical, is the psychological support for persons living with cancer or dealing with a cancer diagnosis. That is significantly lacking. I remember again sitting in there in the room, getting the chemotherapy, and seeing persons who literally had so many questions, who had no answers. And the Jamaica Cancer Foundation, yes, the Jamaica Cancer Society does try to do a lot of work in trying to help assimilate information and circulating it. But there's a great need for that companionship, for somebody to hold their hand while going through this process. It really affected me when I heard Dr. Cox talking about the amount of single mothers who probably soon after giving birth or during the early young stages of their child's lives are diagnosed with breast cancer and have to be facing that battle alone. And that in and of itself is a challenge, being a single parent. But imagine dealing with that with a child. And so in terms of dealing with cancer with a child. And so that level of cohesion and peer support is really very critical. And that is why, like I said, I celebrate and I try to, as best as I can, offer the help that may be helpful to someone else. And I would encourage us to give that support wherever you can. And that's it. That's my perspective at this time.
Dr. Longmore, Sophia, thank you very much. A very rich sharing of personal experience, but also taking it off in directions that tie in with what's going on in the sort of medical, political realm, taking us into spaces around questions of control and preparation, and that control and preparation involves taking care of health in all its different dimensions. Speaking to the uniqueness of your own experience. But as unique as that experience is, it is such that many of us can learn from it. We can learn, all of us can learn that stress is a factor that's going to affect all of us, and that it can have an impact on our body by impacting our immune system and so on, you know. So to talk about the importance of being able to manage stress and to manage our health in all the different dimensions. And you talked about the spiritual, you talked about the mental, the fact too that we really need the peer and family support, and that's important to take us along when we're in those moments of stress and difficulty dealing with treatment. Well, one of the points that you did make which is a nice bridge into Mr. Roberts' presentation, is the emphasis that you made on how important it is to have good insurance. How important it is to have good insurance. Dr. Cox's own presentation talking about all the financial stresses. So imagine you're already financially stressed, and then you end up with this particular kind of disease. You're sort of compounding the pain, compounding the hurt. So if we can find ways of ensuring, getting good insurance that can help us to at least be prepared in that dimension, if, God forbid, we have to go in that direction. So we're glad that we have Mr. Junior Roberts, who's an insurance advisor from Guardian Life Limited, who's going to speak to us this afternoon. He has a lot of knowledge and experience in providing asset and income protection solutions. And we know that 2020 has been a really crazy year. And Mr. Roberts, just in 2020 alone, has worked with hundreds of persons to provide them with a certain kind of stability and a sense of how to mitigate the impact of the COVID uncertainty. So tonight, he's going to give us an overview of the steps that we can take as individuals to implement good insurance, and he's going to focus particularly on critical illness solutions in order to ensure that we have this stability. So, Mr. Roberts, over to you.
Wonderful. So wonderful. Thank you, Ms. Perkins. And it's just such a pleasure to be on the forum. Thank you for everyone who participated earlier. I want to take the time here to share my screen. And as we get ready. Right. So the presenters before has made it, I guess, a lot easier for me to deliver this evening. However, it does not make the task any more simple because financial discussion is one of the hardest ones, especially to have with people in our day and age. We align our financial position with our economic standing, and it hits our ego, it hits our self-image, and especially 2020, while we go through a pandemic, there is so much uncertainty as it relates to what are the implications 2, 3, 4, 5 years down the road as we handle our financial situation. So I usually like to take the approach of working with people on an individual basis. Financial discussions are really personal, and I like to share here a photo of a great family. Husband and wife, and a generation above and a generation below. We all work hard to protect our families. We work hard to protect their futures, ensure that they have the best of everything. But at the same time, there are so many unknowns that comes with everyday living, and the desires of the heart, they're great. So as we evolve as Jamaicans and the whole human race in general, we find that our attention gets pulled away from the things that are important, and we gravitate towards things that are just currently urgent. So it's not the norm for people to, on a day-to-day basis, consider the need for insurance. They think more about the day-to-day meals, the day-to-day financial situation with their kids, running the family, taking care of the monthly bills. And insurance is usually probably even last on the list most of the time. If we could just flip the script and start to teach financial planning from an early age, I find that the habits of proper handling of money makes a huge difference in the long-term outcome of our overall journey. So when we consider this family here, the average person in Jamaica, you understand that there is a huge economic crisis to handle. Even before COVID pandemic, the income by statin, the average income is about 55,000, 60,000 Jamaican dollars. So if you really consider that for the average Jamaican person, their minimum wage or the average wage is not a living wage. So it makes our task a lot greater to help them to plan properly And that's why I appreciate the Guardian group so much, because Guardian Life takes great pride and interest in ensuring that they continuously do assessments, research, development. They're always coming out with new products, bringing to the marketplace. They have decades of experience and it's their main focus. So in 2020 here, I don't know how many persons would follow. They made a major purchase of a portfolio of insurance, billions of dollars, because their actions show that they are committed to the cause of ensuring that people have proper financial planning. And there are a couple of myths that people have around, you know, insurance and financial planning, which is some of the things that I want to go through with people tonight. So on the matter of competitors when it comes to financial planning, it's not just the desires. Other competitors also include death, critical illness, old age, disability, and I substitute pandemics or, you know, viruses here for COVID-19 because that's the one that we currently deal with. So my job is to ensure I get to people before those things or these crises happen. Because while we work, we don't want to work to build a house of cards. We want to ensure that we're building a strong foundation and we live by principle. So here it is that on normal circumstances, two-income families, things are a bit more stable. There's more cash flow in the household. In any event that one or more of those persons who are the main income earners in the family are affected, everything starts to change in the household. And the future you live or the future you set for your kids or your current reality is really a result of the financial decisions of your parents. It's a hard reality to accept, but if we could understand that every decision financially affects the outcome of the next generation, we would take more care to ensure that we do things a bit differently. So that's where life insurance would fill the gap, because Proverbs 13:22 says, a good man leaveth an inheritance for his children's children, which is his grandchildren. If you had a situation 5, 10, 15 years down the road with the initiative with all of the organizations involved, MistyBlue, JIS, Ministry of Health, with partnering with an insurance company to ensure that people are properly protected, then what happens is you would have more cash flow in the everyday Jamaican household. You will have a situation where you have less people doing the reverse of trying to take a loan to fill the gap. Because 4 years ago, the Jamaica Gleaner put out an article that the average Jamaican is paying over 50% of their income towards clearing debt of some sort. When you think about the work you're doing and it's all going in the wrong direction, what happens is it's like you're spinning plates. So it's counterproductive to ignore the validity of proper financial planning in the early stages and end up with a situation where you might use the excuse that I can't afford, I can't this, I can't that. However, what happens is when you're, I guess, held in a tough situation, you are now forced to go further in the wrong direction because you're paying back a loan or of some sort, or you have to sell an asset. I speak a lot of asset protection. The house you work for, the car you work for, I've seen situations where people have to liquidate these things to ensure that they can keep up with what is happening. You see situations where, you know, the parents might work hard to leave an asset for the child mishandle the portfolio, and what happens is by the second generation, everything that the first generation worked for is depleted. So what is wrong in this picture here? You have a $30,000 car payment, a $150,000 home payment, you insure your jewelry, and there is no protection for the family. What you tend to find is people misunderstand the concept of insurance. Insurance is to protect an asset. And in the event that you're protecting an asset, it is very sad when with the quotations of any sort for someone for some form of insurance of any kind, and they can understand the figures, but they don't understand the value. And they're not the same things. If you can understand the relief, the peace of mind insurance would provide, you would redirect your focus on the things that you prioritize, the things that you value the most. It's not the glamours of the world. It's really to ensure that we're living by principle and doing the right things in the right order. So how does insurance help you? First of all, family income protection. In the event that there is, any form of loss of any sort, insurance will fill the gap. Mortgage indemnity. In acquiring any property of any sort, you are required to have insurance. Some people might argue that, well, I've acquired my home and I didn't have to take out insurance. Well, what happened was the financial institution did it for you. And it was a part of the paperwork that you completed without knowing. So every person acquiring a property has to have insurance. The difference, I could discuss in more detail, but when you take out your personal insurance, it protects what we call your insurability. The insurance continues after the mortgage payment is discontinued. However, if the institution takes out the insurance, it's on a reducing balance. At the same time you finish the mortgage, you no longer have that coverage. And if you understand the implications of both, after 30 odd years of paying and now not having adequate coverage, you probably cannot at that time go again for insurance, right? Investment opportunity. Especially while young, I am now spending a lot of time talking to parents with, young babies, young children under 5 years old, that type of thing, to start some form of investment portfolio at that age to fix one of the biggest challenges now. Every professional has student loan. If there is an investment portfolio that the parent has from an early stage, what happens is they could use that money to protect future expenses that will come with trying to elevate and provide the best platform for their children's future. And proper insurance plan forms a part of your overall net worth. A lot of people ignore this factor, but you work to increase your standard of living. Your net worth insurance is calculated a part of that. So Guardian Life has two major critical illness. We're talking about cancer, breast cancer, and I really love the initiative that the foundation has taken because it's really avoiding the system that we really need to fill. So Guardian Life as a company saw it fit to ensure that we have two major plans that help greatly if the need ever arises for a critical illness protection. And the question is sometimes asked, what's the difference between a cancer plan specifically and critical illness? The cancer plan only focuses on cancer, different types of cancer. To some degree, companies might have a guideline or a clause against certain types. So that's for a one-on-one discussion that we could figure out, because you do have rare types. But usually the general types of cancers are covered. A critical illness plan, however, will help you to cover a broader range. So this one that is on the screen here, the Guardian Care Plus, it covers 10 major critical illnesses. And it's available for people from the age of ages 18 to 60, and it's a non-medical plan. The beautiful thing about that is if it is that someone has an underlying issue, they might be able to take this if they cannot pass the medical, so they're not left out of the consideration. However, if you are already diagnosed with any of the major critical illnesses, it removes your chance of getting. So if you should ask the time, what is the best time to have any form of insurance plan or critical illness in place, it would be now, when you're at the best health stage of your life. While you're young, very important. So from age 18, go ahead, help your children to get some form of critical illness. Community, friends, family, relative, church members, help them to prepare properly. And for this non-medical plan, the maximum coverage is $15 million. And here's something interesting about this. Sometimes people ask about cost. Insurance is far cheaper than what you would pay for any loan or car payment or any other form of financial instrument that is some form of loan. So if you should consider someone at 18, I did the quotations, many times, it might be as low as $1,200, $1,300 based on the conditions. Each person's situation is different. Insurance varies based on a few factors. Age, if you're a smoker, non-smoker, there are various factors. So we work with people on a one-on-one basis. But I've done quotations for as low as $1,200, $1,300 for people for critical illness. If you understand the value of that, it's amazing. And obviously it would increase based on the situation, your age, if you smoke, if you've had some form of illness before. But the Guardian Care Plus is one of the best plans out there, and it really helps a lot of people to just have that peace of mind. Here are the 10 critical illnesses we cover. I'll go through them quickly. Cancer, stroke, heart attack, coma, blindness, paralysis, deafness, loss of speech, major burns, multiple sclerosis. As I said, in the wisdom of our president and his group of executives, they didn't want to just single cancer. They wanted to ensure that they provide a portfolio because, the finances are tight. So sometimes people cannot afford to get this plan plus a cancer plan plus another plan plus investment. So they allowed for the grouping of the packages so that it's economical. And Guardian being the largest insurance company in the Caribbean, they are able to provide great affordable rates because of their scale, their magnitude, their imprint, especially in our country. And they can really provide some great financial solutions for you. So we could discuss those on a one-on-one basis. The second plan is the ultimate provider. This one requires a medical, but it covers 23 illnesses, and the issue age is, this should be edited, 20 to 60. So from age 20 to 60, someone can go ahead and take out a ultimate provider critical illness plan. And this one is equity linked, meaning it's attached to an investment. The Guardian Care Plus does not have an investment attached. So this one provides a much better platform. So once it is that you know that you're in good health, go ahead and take out a plan like this one, and the maximum coverage is $40 million. I cannot express how many professionals prefer this plan because, insurance covers your net worth. People who earn a certain amount of money, they want to ensure that they have the best care. And 23 illnesses, it covers a broader range. And here's a list of a few of the critical illnesses. So I'll go through them. Alzheimer's, angioplasty, aortic graft surgery, benign brain tumor, blindness, cancer, coma, coronary artery disease, deafness and loss of hearing, heart attack, heart valve and structural surgery, kidney failure, loss of limbs, loss of speech, major burns, major organ failure, major organ transplants, motor neuron disease, multiple sclerosis, occupational HIV, paralysis, Parkinson's disease, and stroke. So this plan, I recommend it all the time. It's a beautiful plan, especially for the investment. If someone is getting a critical illness in their early stage, it is the best use of their money to have an investment-linked policy. When you know you have to pay your premium on a monthly basis, you're more disciplined towards saving. And thank you so much, Ms. Longmore and Dr. Cox for elaborating on the finances. I want to point this out about the cancer diagnosis section. At the point that you discover some form of illness, those treatments before you're properly diagnosed that yes, it is cancer, there is a series of costs associated, and you cannot claim on insurance policies for critical illness until the first diagnosis. So that's where your investment plan would come in to provide the finances to take care of that series of checks and I guess diagnosis that you need to ensure you can get your treatment. And we could go through these questions in the question section, but does critical illness cover COVID-19? Not at this point. It is new. Most companies were not prepared or even aware of what this is. And, you know, I know our executives are very vigilant, and they will release further updates if that will be something of the future. But for now, no. Does insurance only, is insurance really only for the beneficiary? People ask this a lot. And no, you have more plans in an insurance company for people that are alive than just when you pass off to leave something, right? It's just that society teaches, so the average person you speak to, if that's all they know, that insurance is just for the death benefits, that's what you will also grow with as a notion. And I answered the last question, when is the best time? The time is now. So you can reach out to Dorothy, the Misty Foundation, for my contact info, but here it is as well. The email address, the telephone number. Me and my team, we're always open and available for the discussions. Our turnaround time is quick, less than 24 hours for any queries to be answered, any quotations to be done. And we are very vigilant now more than ever, especially as Guardian has their new drive and nervous, right? As Guardian has their new initiative to ensure that more Jamaicans are properly covered. So thank you so much for the forum. Thank you so much for the platform. We appreciate you and look forward to serve you in any way possible. Over to you, Ms. Perkins.
Thank you very much, Mr. Roberts, Jr. Very comprehensive presentation on what's available in terms of critical illness insurance. And I'm sure you'll be hearing more from the people in the audience. I thank everybody for continuing to remain with us this evening. I thank all our panelists who have given us such excellent presentation. I'm asking you to just be with us for a little bit longer so that we can get some of our questions answered. I do know that there are quite a few questions that people have. And so for the next 10 minutes or so, we're just going to ask questions of our presenters and get some answers. I'm going to take the moderator's privilege to ask the first question. Dr. Cox, my question goes to you. We recognize that breast cancer is not only an issue for women, but that men are also affected by it. I wonder, should men also do self-examinations? And if so, how do we get our men to do self-examinations? Dr. Cox.
It's a very interesting question. I think they can. The thing about breast cancer amongst men, it's for all the breast cancers that you have, the breast cancer in men is less than 1% of all that, and that has to be taken into it. That's a very serious consideration. However, there are men who are going to be in families who with breast cancer, and so they are at increased risk. There are men who suffer. In Jamaica, we have the leading cause of cancer-related deaths amongst men is prostate cancer. And if we look at the syndromes associated with cancer in terms of genetic syndromes, some of those syndromes are causing increased risk of prostate cancer within men, and also an increased risk of breast cancer. And so we have to be, once you have men in a family with breast cancer, ovarian cancer, prostate cancer, they are also of increased risk. And yes, the thing about men though is that men have so little breast tissue that usually if they develop a lump in the breast, it's very difficult, it's very easy to find. It is also very easy to upstage for the same size. So if you have a lady with a breast tumor, a breast lump of 1 centimeter, it may be a very early stage, as opposed to the same man can have a breast lump of 1 centimeter and it's at it's an advanced stage, because there's little breast tissue and it doesn't take much increase in growth for it to attach to the anterior chest wall and get beyond the fascia of the pectoralis major. And so it's very, very important that also that, you know, that men check for lumps in the area of their breasts.
Great. Thank you very much, Dr. Cox. There's a question that's coming to us from Facebook from Delia Roberts. And she's saying, how does one know they have BRCA and ATM? I'm not sure what ATM is, but BRCA, I think, has to do with the breast cancer gene. So she wants to know, how do you know you have it?
Well, the only real way of knowing that you have BRCA or ATM or P53 or any one of those genes associated with breast cancer is by doing genetic testing. You can have on the history of the patient. If you know that there is a patient, if you have a patient who has a first degree, second degree, third degree relatives who have breast cancer at all those generational levels, and you know is a first degree relative of one of those persons, then you are at high risk. And high risk individual mean by whether you use any other models, whether the Gale model, the Claus model, or the therapeutic model. Is a person who you should be thinking about genetic testing and genetic counseling, because you look at the patient and tell, or you can't really do a history and tell, but you can have a suspicion based on risk profile of the patient and the risk assessment of the patient via, you know, reasonable questioning, or you can follow one of the models and it will tell you whether this patient is high risk based on their family history, based on obesity, etc. That they should be one who you can select for testing, especially if the patient now has these things and it's a young patient with symptoms. I mean, I have thought of testing many of my patients who are young with breast cancer, but have hit the roadblock of cost and sometimes the rigors of treating the patient, dealing with the surgery, dealing with the chemoradiotherapy, and now have to think about transporting them in recent times to Kingston for that. It has been very difficult.
Thanks so much, Dr. Cox. Based on your answer to that question, I have a question for Mr. Roberts. Mr. Roberts, does Guardian Life pay for genetic testing? If someone wanted to screen for BRCA.
Could you repeat that, Anna?
Does Guardian Life pay for genetic screening? So if someone needed to do BRCA screening or ATM screening, would they be able to be covered under their insurance with Guardian?
Okay, great. So as it relates to the BRCA specifically, I could get back to you with that one. However, we have 3 major health card plans that people could opt to get, and they get to choose. So that spins off into the whole discussion about health insurance. Most persons that are not employed by a company that provides the benefit are either not aware that they can have it taken out personally, as an individual or for a family, or they just don't have the right, I guess, perspective around the importance of it. So when you choose your plan, based on the price, it also outlines, I guess, what areas are covered. So they are able to design that type of plan within the 3 that Guardian offers.
Okay.
Right? As it relates to the BRCA specifically, I need to just check one of the broker for you, right?
All right, so do a check for us and then share it with the MistyBlue Foundation, and then colleagues will be able to find out more from the foundation. Nicole Smart, I have to come to you because I am very intrigued by how it is that professionals who can show us how to do breast exams and tell us that we must take prostate exams and them sort of things are not themselves doing these things. So how do we get our professionals motivated? I know how difficult it is to keep myself motivated. I can go for a couple of weeks and do my self-exams after I've done, you know, my executive profile. Every once a year, I'll go for a couple of weeks and I'm good, and after that, I'm done. So I'm even challenged myself in terms of motivation. What advice can you provide for us, Nicole? Are you still on?
Yes, I am.
Talk to us.
It's just to keep preaching, because even at this stage, there are still things that I need to do that I don't do sometimes. So what we do now is we keep talking to each other, at least in my corner, and we do have workshops sometimes where we'll try to motivate health workers. So we'll have workshop for just strictly health workers, and we'll try to motivate them to take care of their mental health, physical health, emotional. So it takes everything in, but we just have to keep preaching to each other. And then when persons like myself will get up and say, yes, this has happened to me and this is what is happening, then persons tend to take note and they try to follow on. But we just have to keep talking to each other, because you rightly said medical professionals, they're the hardest and the hardest patients to deal with, believe me. They are. But we have to just keep encouraging each other and motivating each other.
Thank you. So the testimonies from persons like yourself and Dr. Longmore and Mr. Peterkin and so on certainly help to keep the message at the forefront of the minds of many of us. And we're going to take that away with us.
Okay.
Dr. Ong is still with us. I wonder if he could speak to the screening, since we recognize that the mortality rate among the younger people seem to be increasing, the younger women for certain. And then of course, we continue to have increased incidences of different kinds of cancers, breast cancer, certainly among our women. Is there any thought among the medical profession in terms of testing and screening that we make testing and screening to be done at a younger age now? You have any thoughts on that, Dr. Ong? I'm not sure if Dr. Ong heard me. Dr. Ong, we were just asking around screening, if screening ought to be done at a younger age, given, for example, the fact that we are having much younger women showing up with breast cancer.
Oh, sorry about that. I was trying to unmute my mic, and they are not going. I tried to unmute my mic, and I think the guys not talking to me.
You heard the question?
Friendly. Yes, I heard the questions. So I think similar questions being asked in the chat, and I responded to it. Any disease, there's going to be outliers, but we are looking at what evidence suggests locally as well as internationally. So you may have persons coming up with younger group with disease and so on. But my advice to you is screening. But the first thing you need to do is you need to see a medical professional as soon as you have seen some abnormalities, either in your breast or any parts of your body. We're going to take it from there. But for the guidelines specifically speaks for, I'm trying to look for the guideline specifically speaks for women 40 years and older. Dr. Kaus, correct me if I'm wrong, from the Breast Cancer Society of Jamaica, there is a guideline for the general population. So if you're 40 years, 35 or 40 years and older, and you start doing your mammogram, there's a frequency as to how often you need to be doing that. So that's a general guideline. General guidelines for the guideline, but just for the persons who have younger generation, you have multiple risk factors, and you start seeing some abnormalities. Instead of screening, if you screen younger generation, screening is going to be very costly. I know, human life is more costlier than the cost of the money. However, the yield is going to be lower, and also mammogram is some sort of radiation. So would you like to unnecessarily expose the person with that type of exposure? And that's one of the things that you have to balance. So based on all the evidence that you have gathered around internationally and nationally, and we have recommended that there is a standard guideline exists in this country. However, anyone, even you are 5 years old, you're 6 years old, man or woman, male or female, if you are seeing any abnormalities in your breast, please go and see the medical doctor or nurse right away. I just also want to emphasize, or just want to point out, using this opportunity, is that, you know, we have 3 cancers in my medical schools. Our professor was telling me there are 3 cancers that you shouldn't be dying from. One is breast, the other one is prostate, the other one is colon. The reason is being those are what we call accessible area. Breast, you can see it. Prostate, you can feel it. Colon, you can do the rectal examination, at least, you know, those cancers. If you are having cancers inside your body or any other organ, such as liver or lungs or other, you're not going to see it right away. You're not going to feel it right away until sinus symptoms appear. When that happens, it's already late. But for breasts, digital examination, colon cancer, screening guidelines are out there. And also the very important thing is screening is screening, but personal responsibility is playing the major role here in this kind of cancer. Even the COVID, you know, we keep talking about personal responsibilities. So this is my response to your question.
Thank you very much, Dr. Ong. Thank you very much to all our presenters this evening. We're going to have to leave it there. It's up on 8:45 and you've been here with us for quite a while. Thank you all for the great questions. We're sorry we couldn't take all the questions that have come our way, but just allow me to leave you with a couple of very quick takeaways from our session this evening. Take responsibility for your health. Cancer incidence and mortality is on the rise, especially among younger women. So a healthy lifestyle, regular checkups are a must, and learn to manage stress. Gentlemen should also do their monthly checks. Breast cancer is not only a female disease, spread the word. And remember, illness is a fact of life. We have to invest in critical care insurance to ensure that we're able to finance care and treatment if we ever need to. And I'm sure, as Mr. Roberts has indicated, he'll be willing to share more with you as we go along. So once again, I thank you for joining us this evening. Remember to support the MistyBlue Foundation, which is making such an important contribution to cancer awareness and providing support for persons suffering from and surviving cancer. Thanks again. Have a good evening to you all. Good night.
Good night to everyone.
Good
night, everyone.
Good night, everyone. Keep safe.
Good night.
You too.
I was saying to Dr. Chikar.
Thank you.
All right, thanks you all for sharing.
Thank you, everybody.